Thanks, Helen, and thank you very much to the organising committee for giving me the opportunity to speak today. I have to admit to some level of trepidation in tackling this topic. I haven't read a paper in 2 years. Sort of implies you're interested in the most useful research as clinicians, probably the research that's going to change practice. And the research that is going to change practice, we're told, is the big multi-center randomized controlled trials. Hence, as an intensivist, the start of my sort of existential crisis. First, a confession. I'd sort of thought long and hard about randomized controlled trials in the last year that had changed my practice, and I couldn't think of any. I really could only think of one study that had dramatically, suddenly and profoundly changed my practice, and I have to admit it wasn't a randomized control trial. It wasn't even a cohort study. As far as I'm aware, it wasn't peer-reviewed, and to date it's only been published on YouTube. So this is the wind tunnel at Specialized, a bike company that's designed their very own wind tunnel, and they started testing people in it earlier in the year, and one of their cyclists turned up unshaven, hairy legs, and being the good scientists they were, they recognized this as an opportunity. So they thought they'd test him pre-shaving and post-shaving, bit of a joke, see if there's any difference. And actually they were sort of astounded with the results and made a substantial difference. And so they continued to test this on a bunch of other people. Now here's the results for Aaron, Mark, Jesse, James, Luke, and Keith, all of whom they tested pre and post shaved legs. And they found on average a 70-second reduction over 40 kilometers, which for the non-cyclists out there, that might not sound like a big difference, but I guess to put it in other terms, that's the difference between your bog standard, cheap, run-of-the-mill bike and your fancy, flashed aero bike, so a Bic Razor or a $10,000 bike. They even came up with something called the Chewbacca Index for hairiness, and could correlate their Chewbacca Index to the saving depending on leg hairiness. Now, I probably rated myself, although it hasn't been externally validated, somewhere around a 4 or 5. But as I've told my wife, until the evidence changes and there's more available, I'll be sticking at a 0 on the Chewbacca Index from now on. So that was the start of my existential crisis on randomized control trials in ICU. And as a good sort of junior consultant, I went to my senior colleagues and asked for their advice on what trials had changed their practice in the last 12 months. And I got some interesting responses. One talked about the systematic review of cuff leak tests and steroids. I mean, that's a few years old now, but I can see that. Another said that stuff by Prof. Jeff Litton, really interesting on antibiotics, are we underdosing? But as yet, not large multi-center randomized control trial stuff. So I was sort of somewhat reassured that I hadn't missed anything, but it also really made me realize that I didn't have an approach. I was coming to give this lecture about the evidence base, but sort of just looking for anecdotes with which to approach it. So how should we approach the literature? In fact, there's a whole science around this, and it's called bibliometrics. So bibliometrics is the application of mathematics and statistical models to books and other media of communication. And it's fascinating. So this is a graph from a study published in 2005 of all the randomized control trials indexed on PubMed. And the first really interesting thing to note is that it only goes back to 1965. So we have this impression that, well, at least I did, that, the randomized controlled trial's been around since James Litton, 1750, scurvy, vitamin C, all that sort of stuff. But really, the randomized controlled trial is a very recent phenomenon. In the first year of Medline indexation, there were 38 randomized controlled trials published. So you can sort of imagine sitting down every fortnight and getting out your pipe and reading what these crazy trialists have done this month in the one randomized controlled trial that's out there. So it's been a new development, and because of that, undoubtedly, we're still very much in the learning phase. The next really interesting thing to note is the curve of the graph. And essentially, there's an exponential increase in the literature year on year in the number of randomized controlled trials published. This graph only goes up to 2005, and by then there are 180,000 published randomized controlled trials. The Cochrane Central Register now of RCTs at the end of 2013 had 700,000. So the number of RCTs published doubles about every 3.5 years and continues to do so. That might even increase in rate with open access. But if you work it out as conservatively, us being interested in maybe 1% of the literature of randomized controlled trials, and it taking you about 10, 15 minutes to read a randomized controlled trial, then sort of back of the paper envelope, it's going to take you about half your working year to read all the relevant randomized controlled trials published in ICU. So we can't possibly keep on top of everything. If you delve a little bit more into this sort of area of bibliometrics, you come quickly across this concept of core and scatter, and that's sort of Bradford's law. And that really states that you have this core of randomized controlled trials in a few select journals, and then this huge scatter, and it's represented by this ratio of 1 to n squared, meaning that if you take all the randomized controlled trials for a particular area and lump them into 3 equal piles of numbers of randomized controlled trials, the number of journals you'll find them in will be 1 to n squared. So there's a core set of journals that has a lot, and then the rest are scattered over a huge amount of journals. And in fact, I don't know the numbers for intensivists, but for a diabetologist to read only 50% or locate 50% of the randomized controlled trials available, he or she would have to read or keep up to date with 39 different journals. So there's a huge number of journals. If we think about just keeping to the core journals, how do we decide what's important or not? What's important sometimes in the literature is defined as these citation classics. How many times has a paper been cited in the literature, and how many journals have these citation classics? Arbitrarily, that's often defined as a sort of citation number of over 100. If it's been cited over 100 times, it's a citation classic. Obviously, that doesn't help a lot when you're looking at the literature in the last year, because there's a time lag there. And there's also a number of other problems with that. Here is the most cited retracted paper in the medical literature. So Andrew Wakefield's paper sort of, he's been subsequently struck off the medical register in the UK, but this was cited 738 times before it was retracted. So citation isn't fantastic. Another interesting thing you do is if you go to the websites of these journals, as well as the high citation number, they have the access number, and the trials often don't correlate between those that are highly cited and those that are highly accessed. But highly accessed is a problem too. Here's this year's winner of the Ig Nobel Prize for Medicine, nasal packing with strips of cured pork, which you might access it often, but probably unless you're, a butcher with some sort of bleeding disorders, not of much clinical relevance and won't change your practice. So looking at highly accessed isn't useful either. We do have a little bit of data on the most influential articles in critical care itself. So if you take just highly cited articles, over 100, and look at which journals have the most of them, then we get a hierarchy. In fact, as of sort of 2010, there were about 1,200 highly cited ICU articles, and those were found in nearly 100 different medical journals. So there are critical care ICU articles that are highly cited in nearly 100 journals, the most highly cited of which is, as of at least 2010, was still the Naus paper on Apache 2. But critical care medicine has the most, followed by New England, then JAMA, and then American Respiratory and Critical Care Medicine. So you can get a little bit of a feel that you probably need to concentrate on some core journals. The core journals probably have the most highly cited articles, and in the absence of a better way of approaching how you look for articles, that's probably a reasonable way to go. One other thing I thought was worth mentioning in terms of another way of looking at this is research, critical care research productivity. And this is a study published, a bibliometric study published in 2012 in the Journal of Critical Care, just looking at publications by country and then publications per million. So critical care publications, the United States has by far the most, United Kingdom's down after that, Germany third, Australia fourth. If you look at it by publications per million of population in the critical care literature, in fact, Australia comes out on top, just ahead of the Netherlands and I think Switzerland. So per million of population, we're productive. Is that important? I think we think it is in terms of access to sort of opinion leaders, translation of research into practice. There is actually also some evidence to back up the utility of this. Here's a study published in the healthcare literature looking at the correlation between innovativeness and hospital-level outcome data. So the researchers here quantified innovativeness on 3 domains: the number of research grants per FTE of specialists, the number of projects underway at the hospital in terms of number of specialists, and the number of publications per FTE. And they found, accounting for, I think, a pretty reasonable number of confounders, university status, trust size, all of these sorts of things, that there was a strong, statistically significant correlation between innovativeness on those 3 domains and mortality. So it probably is important. Then we come to how we actually apply this to the literature in the last year, and that's when you have to keep calm. So what do we find in the last 12 months? Well, if we go to the top general medical journal for citations, we come across 4 randomized control trials, none of which showed benefit. I agree entirely with Sandy yesterday that these are not negative trials. They're hugely informative in terms of the literature, but none of them found the benefit that they were hoping to find when they set out. The top specific critical care journal, Critical Care Medicine, I've limited it here purely to the sepsis studies, but again, no difference. Phoenix was stopped early because of potential harm, but none of them found any difference in their primary endpoint. So glass half full or half empty. Arsenal suffered a 2-0 loss to Chelsea at the weekend. Managers pushed each other around. Could go either way. We come back to this. It's interesting, you know, I picked out this study and it's already sort of caused a lot of debate in the last day. This is the JAMA article of the core data published from Australia and New Zealand from 2000-2012, which was primarily looking at sepsis. Now, the adjusted odds ratio for mortality, 0.49. And undoubtedly, as an observational study, you know, despite these very narrow confidence intervals, because the study was so huge, over 100,000 septic patients, there's the potential for residual confounders, there's the potential for the drift in the adjustment with the Apache over time. I'm less interested in the absolute numbers and where it sits us in the rest of the world. I'm much more interested in the sort of questions this study raises. Let's assume that sepsis mortality is going down, and like the paper suggests, it's going down concurrently with mortality in general. We don't need to worry if it's quite as marked as that, but it is going down. The paper raises a lot of interesting questions, and the paper asks itself a couple of really interesting questions. The first is, what is the attributable mortality from sepsis? And this is an absolutely key question. You can't answer it definitively from this study, but it gives you a pretty good insight to what sort of attributable mortality we need to be looking for. There's no point designing trials where we're looking for a huge reduction in mortality if the attributable mortality is less than that. So it brings up this concept of marginal gains. In the JAMA paper, to try and look at attributable mortality, they selected the subgroup of young patients, less than 50, with no comorbidities, and found that in fact the mortality in 2012 of those patients is less than 5%. So if we're going to be looking for benefit in randomized controlled trials, well, we need to be powered to find that sort of marginal benefit. It brings up this concept of marginal gains that I'll come back to. The second interesting question, which has already, again, sort of elicited a lot of debate, is, well, why is mortality decreasing? You'd love to sort of see this stepwise decrease where you could put up your randomized controlled trials that showed benefit and see it sort of dropping progressively. We haven't had that sort of findings from a randomized controlled trial so far, but mortality is decreasing. And Dave Pilcher touched on a lot of this yesterday, but one area I wanted to go into was managing complexity, and why in ICU managing complexity is so important. In the paper they talk about, well, maybe it's just housekeeping, but to me, housekeeping it undersells a lot of what we do. It sort of implies you're just dusting off a few old relics whilst, someone else is out doing the heavy lifting. But we do a lot more than just housekeeping, and I want to sort of go into that interplay between acute physiology and comorbidities and try and delve into that a little bit. So managing complexity is interesting. Complexity is the amount of information required to describe something. And the Boston Consulting Group has come up with this thing called the Complexity Index. So it's an actual numerical measure of the complicatedness of things, and they can measure it. And they've shown that in business, over a sort of similar time frame that we've been indexing RCTs on PubMed, complexities increase by a factor of 35. Now, you never sort of create or identify a problem in business that you can't be paid a lot of money to solve. But really, their solutions come down to a lot of the things we do in intensive care or want to do better. The first is cohesive teams. A team approach certainly helps when you're dealing with complex issues. The acceptance of a knowledge deficit. We know that no one player in the team has all the knowledge, and we rely on others to help us out. And I put this one in italics. It's because I didn't think we did it so well, but maybe I'll reevaluate that. Extending the shadow of the future. So it's a great term, and it comes from game theory, and it's really about making us accountable for our future actions. I think we're some of the way there. Dave Pilcher talked about how in the distant past we didn't even have the core data to look at an aggregate level, unit level sort of results, but we don't have yet the individualized data, the outcome data that we want, and we don't have it long term in a way that helps feedback on our performance. So if we look at managing complexity in the ICU and our patients, it really comes from two things, and there's a really interesting, I think, discrepancy. Short-term mortality is primarily determined by the admission diagnosis, but if you're looking for things you can vary, the extent of the physiological derangement. Whereas all the work on long-term mortality, some of which has been done by my colleague K.M. Ho in Perth, primarily determined by age, the biggest potentially variable determinant is comorbidities. So there's this discrepancy between what determines your short-term mortality and what determines your long-term mortality in terms of the interventions that are going to be variable. Where that crosses over is going to be individual, but it makes sense that the quicker and the earlier you get on top of the acute illness, the physiological derangement, the greater is going to be the earlier the long-term mortality is going to be determined by the comorbidities, and the greater the effect of the comorbidities on outcome. So the quicker we get on top of it, the earlier in the piece we admit people, the bigger this issue of comorbidity becomes. And Dave told us yesterday that progressively over time, the acute physiological derangement of the patients we're admitting, either it's a numerator or a denominator issue, is decreasing to our ICUs. I think if we look to the surgical literature, this can give us some really useful insights. There's a concept of failure to rescue, and a really interesting paper in the New England in 2009 that took 80,000 patients having inpatient general or vascular surgery, elective surgery in the US from 71 different centers. And they found effectively a twofold difference in mortality, accounting for sort of acuteness of illness and everything else they could think of. There was a twofold variation in mortality outcome, 3 to I think about 6%. That's perhaps not surprising. What maybe is more surprising is that the complication rate, both general and major, was similar between those with high mortality and low mortality. So both groups experienced similar complication rate, but it's the response to that that varied. So if you're in a high mortality group and you have your complication, you're twice as likely then to die as if you're in the low mortality group and have your complication. So the response to when you get your complication was the primary determinant in the variation in mortality outcome. Now, we don't yet have the sort of, the granularity in our outcome and our morbidity and mortality data to tell us this, and maybe it's a bit more complex because our patients are more heterogeneous, but it's certainly plausible that some of the mortality benefit we might find is from our response to complications, and the response to complications is going to relate to comorbidities. Okay, well, I'll quickly whiz through this. As well as this issue of complexity, I wanted to talk about marginal gains and how we're going to achieve those. So if we're not looking for huge gains, but there are still potentially marginal gains, what are we going to do? This is David Brailsford. He sort of popularized this term of marginal gains. He's the team leader for Team Sky and Cycling GB, responsible for two Tour de France victories, something like 18 Olympic gold medals, and numerous other championships. Delta inflation is a lot of the problem. So we have this issue where the incremental benefit we're seeing from our interventions in randomized controlled trials is roughly of the order of 1.4%, whereas what we're looking for is more like 10%. If we're going to bring those closer together, how are we going to do it? First of all, I think is the unsexy stuff. So here's Dash Gartner's data from after-hours discharges, and shows that really there's still a very increased risk of mortality when you're discharged after hours, and those are graphs superimposed from 2005 to 2012, and the reason they're so indistinct is because they're very similar. We haven't improved. Another part of the unsexy stuff is this translation of research into practice, and this is from the MJA just last year, listing 10 interventions that have been proven to be ineffective or harmful, and in that list already they list tight glycemic control and steroids for head injury. These are things we think we don't do, but we don't know. We need more sort of the translation side of things. Mega trials is next. If you want to find small differences, you need big numbers. And one of the great advances, I think, in the last few years is harmonization. So ARISE, Process and Promise had harmonized at the outset their data fields as much as possible, and they can do an individual patient data meta-analysis. That's superb, and that's a long way along the line to finding these small differences we're after. The second is the fact that critical care trials groups are sort of exploding all over the world. This is the TTM study, a fantastic, pragmatic, randomized controlled trial done by the Scandinavians. There are more and more groups with which to collaborate with and run big trials over multi-centers, and I know the SDD collaborators are trying to do that now. The third, and I can only touch on this briefly, is other important outcome measures. Rightly, we're sort of fixated on mortality, but there's more and more evidence of the morbidity long-term associated with critical illness. This paper from New England last year is fascinating, I think. It took 800 survivors of septic shock, cardiogenic shock, and respiratory failure and looked at their cognitive function at 12 months. And nearly a third had cognitive functioning consistent with moderate TBI, and about a quarter were at a level consistent with mild Alzheimer's. So, you know, these are really important patient-centered outcomes that we need to start designing more trials around. The final thing is novel trial designs, and I think this is another really exciting area. This is taken off the Wellington ICU website, and it's the statistical analysis plan from Paul Young's SPLIT study that is a cluster crossover, in fact, double crossover randomized controlled trial. So this is just going to run for 28 weeks, 7-week block, so it's a fixed length of time, and in that time, in 4 ICUs, he's randomizing around 2,500 patients to receiving either saline or plasma-like 148. And the crossing over negates a lot of the decrease in power issues you get from clustering. So that's a fascinating area. So is Bayesian methodology. So Bayesian trials use a different approach, the frequentist approach, where you've got a prior probability and a likelihood ratio, and that informs your posterior probability. And yesterday there was a lot of talk about sort of individualizing treatments. Well, this is almost individualizing trials. They've already had trials going through the FDA, approved on this basis. Pharma does it a lot for their at least phase 1 and phase 2 stuff, and it'll almost certainly be coming to an ICU near you. So in conclusion, I'd say a cyclist with hairy legs is like an intensivist still practicing early goal-directed therapy, working too hard to get to the same place. And the glass may be half full or half empty, but the only way to find out is to randomize. Here's a picture of the new Fiona Stanley Hospital, brand spanking shiny new tertiary hospital in Perth, Western Australia, 40-bed ICU that's just opening up and a lot of us are moving to. Thank you very much for your time.